I'd like to invite the next speaker, Brenda King, MBE and nurse consultant at Sheffield Teaching Hospitals, who's going to be talking to us about leading change and adding value and reducing unwarranted variation wounds of the lower leg.
Thank you. I was actually going to apologise because I know there's a few people in the audience that have heard this, not twice but 3 times, what I'm going to say. I'm not going to make any apologies whatsoever. Until we get this right, until we get wounds of the lower leg managed appropriately, I will keep talking, and certainly after listening to the previous speaker. It is part of the NHS RightCare programme, and I'm not going to go into any detail about that, about using innovation, about using intelligence, and about implementing those changes. And I think one of the things that will come out of the NHS programme is more data around wounds, more data around wounds in general. And I think what we'll begin to realise is the majority of wounds that we see are wounds of the lower leg. And I think it's how we start to interpret those wounds of the lower leg. The NHS work streams, there are a number of different ones. There's the Wound Assessment Minimum Data Set, which I'm sure you've all seen now. This was released on the 30th of March. There was Sequins that started as of the 1st of April, which is looking at assessment in isolation, hopefully going to lead to better outcomes, but we need to make sure that it does lead to better outcomes. So we will have more information about wounds and about wounds out there. There is the economic analysis, there's the React to Red programme, there's education and competencies, and there's also a work stream looking at commissioning, and then the lower leg pathway. And I think it's absolutely essential that some of these work streams actually do come together, because there's no point in trying to develop a lower leg pathway if it doesn't have the education and competencies, if it doesn't have the commissioning of the services, and if we don't get that service actually right. I feel like I've been doing this job for a long time, and over that time I've done numerous counts of lower legs locally, or the wounds on the lower legs. And in 1992 I asked about ulcers of the lower leg, and that's the results I got. 245 wounds of the lower leg recorded as ulcers. And as you can see, there's a mixture up there, venous being the most popular. Very surprising this, because you know back then we didn't really have that much in terms of how we assess and diagnose these wounds. We actually looked then at lower leg ulcers, but more of a wound count back in 2007. And as you can see there, we've got a much higher figure. This is the community nurse, and we did have a few practice nurses responded as well. And we'd started to then look at how many of those had actually had a Doppler performed as part of that assessment. And as you can see, it's not brilliant. And this is an area where we feel that we're constantly putting education in place, developing services, developing leg ulcer clinics. We did a wound survey in 2013, and again, it was just asking about wounds. And interestingly, we could correlate quite a lot of this information. We can look at the actual location. And when we look at the location, clearly there were well over 600 wounds to the lower leg out of a total of 1,230 wounds. So we could see that we'd got the biggest population of wounds were to the lower leg. But when you start to look at the type of wound to the lower leg that was being documented, very few were in that venous category. Yet we've been told for a long time that venous is the most common cause of a lower leg wound that fails to heal. We could look at the duration and correlate that to the wound type and the location, and clearly we've got pretibials, we've got skin tears, we've got hematomas, we've got wounds that were on the location of the lower leg that had been around for 6 months and longer. So we'd got chronic wounds in these categories that were never put into another kind of category. We did a lower leg project in 2015 and re-audited in 2016. And one of the interesting things that we saw was despite having incredibly motivated teams, good pathways in place, we still kept them in that category of edema, of skin tear, of laceration, of pretibial, and the venous category was still quite low. We did improve, but we're still not improved sufficient to for me to want to shout about it. We're seeing more patients. We've got more complex patients or more complexity to the problems that we're needing to deal with. We've got more patients with bilateral leg problems. We've still got patients where we're not identifying what underlying problems are. We've still got a lower count of that venous. We're getting better at filling in a wound template. We're getting better at doing the Doppler. We're doing them in a more timely manner. But we do realise we've got nurses going out with 20 visits. And somehow the capacity has got to be looked at in order for them to deliver care appropriately. We know if we treat venous leg ulcers properly, we get good outcomes. We know if we don't pick it up straight away in that lower leg wound pathway, we'll have chronic problems. Both of these wounds, I don't know how clear that image is for you, have been sutured. And neither of them have had any underlying problem addressed. So we need to think about the emergency departments. We need to think about walk-in centres. We need to think about areas where they are seeing these, and it might not be somebody necessarily with a venous problem. We had a relatively young chap that tripped up getting on the train, had a pretibial hematoma, and 2 months down the line had a few visits to walk-in centre and a couple of lots of antibiotics as well. We get it wrong, and we do have, some quite significant consequences. And we need to think about the treatment of that leg. And this is a management of a pressure ulcer going off here. But, it's important that we need to think about that whole leg. We get it wrong, and it has even dire consequences, limb-threatening consequences. So we need to make sure that we've got the right skills to deliver once a diagnosis has been made. We miss the diagnosis with a basal cell carcinoma, and it's not such a serious outcome. It delays treatment, it increases that suffering and increases costs. We miss the diagnosis with squamous cell carcinoma, and we've got much more serious consequences where it's limb-threatening and life-threatening. So there are some serious consequences to missing problems with lower leg wounds. We've got to be absolutely sure we've got that skilled workforce. And we talk about non-concordance. I would question whether anybody in the room would leave this alone. I would question whether anybody in the room would actually go to bed with that, and then we would say they're non-concordant because they're not resting and elevating. These were removed by the patient and reapplied. So we need to be clear what it is that patient needs. Are we communicating well enough with what the patient expects? And why do they feel they've got to please us in putting bandages back in place? The cost to the patient, I don't need to talk about this. I don't need to mention this, that I'm sure we've all been in that situation where we had the old boots, that's the only pair you ever had. I think we've all got 3 pairs in Sheffield now. But we had major problems. But are we managing this appropriately? But we've got guidance out there, haven't we? Why haven't we not got it right? Why is it not right? We've had the sign guidelines have never been re-looked at. We've got this, the RCN guidelines. The sign guidelines are there. But do we need to re-look at these? What has happened since 2010? We've got much better advances in vascular surgery. We need to be recognising some of these in our pathways. We've had some publications on NICE in 2012, we've had publications in 2016, and we've also had the best practice statement. What is common about all of these? They're all talking about venous leg ulcers. And what I've demonstrated in some of the surveys that we've done is that we don't move them into a venous category. We're actually keeping them in the category as they present. But we may be treating them or treating the venous condition, but it's still labelled as a pretibial or edema or a skin laceration. So I personally think we need to change the way we talk. We need to think about using the word venous. We need to think about a wound to the lower leg where the patient may well have got a venous condition or an arterial condition or other comorbidities that impact on the healing. Betty's story, I felt Betty was actually real and worked alongside to try and actually develop this. And I hope everybody's looked at that, and I hope everybody's looked at the wound, because that wound is a real patient, and that's one of our clinic patients. And if you take another look at it and look at that wound, that patient was self-treating that wound at that stage. That's at first presentation. So you're absolutely right. Somebody's selling products to patients. I've been in a chemist where a patient's actually asked in front of me for dressings for the lower leg. We were actually on holiday and my other half had to hold me back. Brenda, don't say anything. But it's that kind of thing that we need to acknowledge, and we need to put the pathway in at that point. The questions are going to be out there for commissioners as part of that Betty's story. But again, we're focusing very much on venous. And if we give the answers on venous, but we're not collecting data as venous leg ulcers, again, we might not have got that right. I want to say who actually needs Betty. This is me. My mum would say that's a supercilious grin. It isn't, it's because I'm scared. Because my brother had got me walking round here, and I hate heights. It's a couple of stories in here. One is about being prepared for the job that we've got. To actually do this, I was given a hairnet. Some people might say that's probably a good idea, and a helmet. And I'm not quite sure that prepared me for walking around there. But the reason why I wanted to talk about this, we were on holiday with my brother-in-law. This is at the end of January, beginning of February. This is Richard. I don't have Richard's permission to use these. I'm not really bothered. I'll get him back one way or another. But Richard works for the NHS. He's a driver for the NHS. Richard is overweight, admits he's overweight, and he walks with quite a poor gait. Richard didn't come on that walk with us, but we spent the majority of the holiday with them, or with my brother and his wife. And as the weather got a little bit warmer, Richard put his shorts on. I'm following Richard and I'm looking at his leg and I'm saying, Helen, I don't like the look, which is my sister, I don't like the look of Richard's leg. And she says, no, Brenda, neither do I. And I said, well, I'm worried he's going to develop an ulcer. She said, well, I think he's already got one. She said, it's leaking and I've been using a bit of hydrocortisone on it, which dries it up. And I said, Helen, what's my job? I have a family that ring me about every medical condition going that I haven't got a clue about. There's one about leg ulcers and they don't ask me. But the bottom line is Richard's frightened to go to the doctors. They're going to tell him he's overweight and that's his problem. That is how he feels. But before we came home, this is 2 days before we came home, Richard had actually got an appointment to see somebody. That's what he was told. Double base, Betnovate in the morning, he didn't need compression, that's how we treat it. How do we change it? Because there is a named nurse in that practice who deals with the leg ulcers, but at the reception point, he was told he didn't need to see that person. So what do we need to change? We need commissioning. We need to make sure that the commissioners are on board. We cannot have practice nurses doing 10-minute slots and managing a leg ulcer patient. It does not work. Some are commissioned longer, but some have just got the 10-minute slots. We need new, nice guidance, but we need new, nice guidance that's not talking about venous leg ulcers. We need the lower leg wound. We need to think about standardised service. We need to think about pathways, but we don't need to think about pathways being an identical pathway. They've got to vary across the country because service provision is going to be very different. And I don't care who delivers that service as long as it's the right person that the patient sees. It doesn't matter if it was a pharmacist as long as they're trained and have the skills to do so. We're all working in areas where I'm sure we deliver good practice, but it's about how we can make sure people outside our practice have got that right. And I'm out of time. But just to say, we have got a draft national framework out. We've got a draft sample toolkit that would raise awareness. We've got recommendations out there for the guideline review by NICE, and we've also looking to see what recommendations we need to look at for further research around the diagnosis of lower leg wounds. And we're going to hear from Una about joining forces to champion the project. Thank you.
Thank you, Brenda. I think as we've run out of time, if we could have any questions for Brenda at coffee time, and if we could just move on to the next speaker. I'm sorry.